respect to the dais and thanks to Dr. Partha for this wonderful opportunity. I start this topic on subluxated cataract in a VIP patient. As Dr. Chandra said, it's very important. Dr. Manisha said that it's important to counsel. It is important to counsel a VIP patient time and again, and also to counsel yourself. Not to be in panic, explain the prognosis and go ahead. I think the final thing is your expertise would solve the problem. So subluxated cataractus lens, and that too in a VIP patient, can be a nightmare. So a pre-op evaluation aims at looking for zonular integrity, degree of the subluxation, specific etiology, and any complication in addition to the routine investigations. So indications for this urgent intervention requires to know whether there is pupillary block glaucoma, intractable uveitis, lens corneal touch leading to corneal decompensation. In children, there is always the possibility of amblyopia. So how to go about the pre-op evaluation in any case of subluxated cataract is we should know what is the lens subluxation, whether it is minimal to mild, when the lens edge uncovers 0 to 25% of the dilated pupil. Moderate, the lens edge uncovers 25 to 50% of the dilated pupil, and whether it's a severe kind of subluxation, and that is up to or greater than 50% of the pupil. We need to know whether there is a phacodonosus as cataract, whether we can see the subluxated lens edge, whether it's a flat lens edge, when the remaining zonular fibers, they are fairly healthy and strong, and round edge of the lens, whether it's visible or not. Pre-op evaluation also includes the change in the position of the lens with posture. If it is there, we have to be careful. UBM is valuable to know the zonular compromise. Lens capsule damaged or it's punctured, intraocular pressure needs to be monitored, and vitreous status has to be seen. So surgical approach is there when we, if it is a traumatic subluxation less than 3 clock hours, attentive surgery is required. There is no need for any capsular support. If there is a mild zonular laxity with progressive pathological state, sometimes there is uveitis going on, use a CTR. And if it's a young patient with progressive diseases, sutured a CTR with scleral fixation, even if the lens is not displaced. So capsulorhexis, how do we go about it? It's always there's a difficulty in puncturing the anterior capsule. We need to use trypan glue dye. The elasticity of the capsule is reduced. Penetration of the bag and propagation of the capsulorhexis is easier if we use some device like hooks and all, and it aids in visualization of the avoiding unintended capsulorhexis. So crossroads capsule pinch approach, you can use that. Microforceps are required or hooks may be needed to steady the lens during the continuous tear. Capsulorhexis is centered on the crystalline lens, that's very important. It's not on the pupil, has to be on the lens. Or the corneal apex, that should not be taken into care. It is the lens which has to be taken care of. The center of the rhexis starts in the lens. Minimum 2 mm margin should be there between the capsulorhexis edge and the equator. We need to stabilize the capsular bag. Flexible iris retractors, they are placed through limbal stab incisions, and there is less than 3 clock hours of zonular deficiency. Stabilization of the capsular bag, if it is more than 6 clock hours, use CTR rings. CTR selection is also based on this. If there is more than 4 clock hours or moderately to severe displaced lenses, we can use a fixation device like standard CTR and a ring segmentation in combination. Need to suture sometimes. So long-term stability can be achieved using a Sioni style CTR or Ahmed type. In cases of severe weakness or progressive disease in younger patients, any combination of these devices could be used. Phacoemulsification should be done. Hydrodissection and viscodissection, they are critical tools in managing these subluxated lenses. The youngest lenses can be aspirated with irrigation aspiration handpieces, and abundant use of viscoelastics is must. Cortical aspiration has to be taken, good care has to be taken. The aspiration should be from the anterior capsular rim edge towards the equator and should not be directly sucked from the equator directly. Centripetally it should not be done. That might increase the zonular dialysis. Intraocular lens selection is important. We should avoid accommodating IOLs. 1 piece or 3 piece IOLs should be the appropriate IOL for insertion. Toric IOLs in subluxated lenses, they should be avoided because there is a risk of decentration and improper alignment. Possibility of late suture breakage is there. Progressive zonal degradation requiring late lens in the bag fixation with possible IOL rotation is there. So a better alternative is limbal relaxing incisions are given in cases of any astigmatism rather than going for a toric IOLs. Multifocal IOLs, they are beneficial in young children because in atropia lenses, as we see, that there is loss of phakic accommodation. So then multifocal IOL is the better choice. We can use PTFE instead of ninoproline when we use multifocal IOLs. Vitreous prolapse has to be taken care of. That has to be done very calmly and nicely. We should use a fast pen approach, that is better. Once the prolapse vitreous has been removed, place a dispersive viscoelastic over the exposed region. This limits the additional prolapse during any subluxation of the lens. So this is a case which I recently did on a patient, a VIP patient. It did not alter my surgery. We can see that CTR is placed. This is moderate kind of dialysis. CTR is placed before I took out the soft cortical matter. It was not all that hard. You can chop and aspirate without causing any zonular increase in the dialysis of the zonules. All the procedures are done with care. IOL implantation is planned. You can see it's being placed in the bag and secured properly. The center is nudged. This is how a subluxated lens is tackled with. Different cases need different maneuvers. You should be expert and beginners should take more care. With passage of time, we get to learn. Every case can be done with a lot of ease. So thank you very much, Dr. Manisha.
Thank you, madam. So in case of subluxated lens you have, it comes with the trauma, the least traumatic approach, what would be your least traumatic approach in those kind of cases? What kind of, whether would you like to try the same lens and do multiple procedures which have been described, or would you like to explant and come back with a new lens in those cases? And if yes, what would be your choice of still fixated IOL?
For me, I think I can manage the subluxated lenses like this approach which I showed you. In a similar manner, I do in any VIP case also. And regarding scleral fixated lenses, I use sutures. I use duoproline and fixate the IOL on the standard previous style kind of situation, not the new glues I don't use. And CTR can be used as if required. Nothing more. If CTR is required, I do. Otherwise,
so there are various still fixated IOL techniques. Dr. Abdul Gupta here to my part for a beautiful video about how the both RD as well as the SFIOL, choice of the SFIOL. Any comments from the chairperson? The choice of the SFIOL, the sutured versus sutureless. In sutureless, you have so many varieties now. Sergio Canabrava technique with 506 is also being used. The dumbbell shape technique, or the Yamane, of course, the modified Yamane. The Indian Jurats have started happening now. Various people starting their own technique and calling it as a modified Yamane technique. So, any comments? like sir, first the finger is better. Very true.
But I use only tenofrolene for this suturing. Never depend on the glue.
The only disadvantage with these tenofrolene is now we are seeing the degradation which was done 15 years back.
That is true.
And I have shown a series of cases where we do the dangling SFIOS, where we try to just hook up the thread in the vitreous cavity and bring it back. Either you can use a tenofrolene or you can use 6-O-protein inside the vitreous cavity to thread it in the eyelet of that SFIOL and then bring it back, and then you can flange it. So there are various multiple procedures also being discussed in the dangling. So I think any experience about anybody in the audience regarding the Gore-Tex SFIOL, and they are said to be the best. So if we are thinking that there is any VR intervention going to happen in future, then I think the stability of these SFIOLs is very, very important, because the 2-point sutured SFIOLs will not give that kind of stability as with the 4-point fixation, or with the kind of Gore-Tex securing the 4 places, the suture knots. I think that's going to be more stable. The only thing we worry is the oil or the gas coming into the anterior segment, and we all know that if gas comes into the anterior segment, especially the CTFA, it's definitely going to cause more damage to the cornea and the increased glaucoma as well. So any thing, yes sir, about the goal. Come on sir. Gore-Tex, sir. Very interesting. I think you should publish it, sir, so that yeah, because many of us would like to know, because as we all know from the outer side is, yeah, it's a very safe this thing, but definitely these kind of reports will definitely help us. Well, what might be the reason for the for this increase? Because you really buckle also you.
Close the session now. It's time.